Thanks. Thanks, Roger. I can't follow that very easily, but I'm going to try. So what Roger really meant to tell you was, whenever we happen to be in a meeting together and somebody says Roger, it's really Roger Prudham they're asking, because he knows all about it and I don't know anything at all about any of it whatsoever. In particular, they're all fascinated by the fact that he's got a fit test in his top pocket. And he does a bunch of party tricks that I can't get anywhere close to with his fit test. And that sounds like a small little amusing anecdote, but seriously, massively important approach that Roger's had in leading the push to get us into a better position in the early diagnosis stakes with the use of fit testing. And obviously, Roger's not done every single one on his own. He's done quite a lot of them. But what he's managed to do is get us facilitating a set of circumstances where you and your colleagues have really shifted us in the last 12 months in the early diagnosis stakes using fit testing. The numbers are impressive, and of course, they turn into some better outcomes for patients. So I shut up waffling on now and get down to what it is that we're all about in this session. It's really great to see so many of you here, particularly when we're in these really challenging times. It's really impressive to see all the work that's gone on outside of the meeting. The posters are incredible volume of posters activity for one of our pathway boards here. So really great to see so many of you. I've got the pleasure of introducing a session here which has got a couple of things in it. The first is a recovery plan for CT colonography services, I should say, and we're going to get an insight into that shortly and have an opportunity for questions and answers. And then we've got some exciting activities looking at some of the colorectal findings in the gallery study, which I know many of you know quite a bit about, and it's all quite exciting activities because, you know, this is really the future, or it's certainly part of a contribution to the future. So really excited to get that going. So without further ado, I'm going to get our first presentation up, which, as I say, is about recovery plan for CT colonography series. And I'm going to invite, and we've got some experts here, but I'm going to invite Dina Awad, who's a consultant radiologist from and clinical lead in GI imaging from MFT, to come up and start us off in this session. Over to you, Dina.
Good morning, everyone, and thank you very much to Roger and Roger for introducing the session. It's very difficult to follow the two Rogers, so I'm going to try and do my best this morning. So my name's Dina. I'm a GI radiologist from MFT, and I'm currently the clinical lead for GI imaging at MFT. I'm very, very pleased to be here to introduce the really extensive collaborative work that we've been doing across GM, looking to improve and standardise how we do CT colonography and try and improve our turnaround times and access to the pathway in general, with a view to just improving patient care on the pathway. So if I can figure this out. So the way I'll do this is by talking you through the context, the background, the challenges that we've had, how we set about setting up the team that looked at the challenges and the solutions that we're going to try and find, the key areas of work, what we standardised, and how we went about it, and then some early successes, because this is fairly new since the ratification of the guidance through the Colorectal Pathway Board. So I thought I'd take this sneaky opportunity just to talk to you about CTC and how we do it, just to enlighten you a little bit as to what the technical considerations are when you're thinking about requesting a CTC. So it's by no means an easy test. It's perhaps a little bit better tolerated than colonoscopy, but it still involves significant bowel preparation. The patient has to be fit enough to be able to take full laxative preparation and fecal tagging material. They have to be independent enough to get to the toilet, or at least have support to get to the toilet. And then on the day of the test, they have to be able to get onto a fairly narrow and hard CT scan table, as you can see here. They lie on their left-hand side. They have this rectal catheter introduced, which some patients are surprised about because we're lacking a little bit of patient information before the day of the test, as we'll allude to later. We then proceed to introduce anywhere up to 5 litres of CO2 into the patient's colon, which is not a pleasant thing to have done. And you have to be reasonably robust to be able to tolerate it. We then ask the patient to turn 360 degrees on the CT scan table, which they have to be able to do independently if possible. And then we acquire 2 CT scans through the abdomen and pelvis, one in the prone position, which is the patient lying on their front there, and then a second one on the back following the administration of IV contrast. And ideally we give the patients IV Buscopan as well if it's not contraindicated, and that gives us a nice relaxed colon that we can fill with gas and gives us better quality pictures in the end. So you can see that a patient who's wheelchair bound or really frail, hoist, all those kind of mobility and comorbidity issues, this wouldn't be a suitable test for them because it's reasonably grueling. So what do we get then as a result of doing all that to the patient? Well, so the picture on your left is a scout projection, so it shows how much gas there is in the colon when we do the test. And then we get these beautiful 2D typical CT pictures where you can see the colon's beautifully distended, full of gas, and the white stuff is the fecal tagging material, which helps us to distinguish between a colonic polyp or a colonic cancer from residue in the bowel. And I guess this is one of the advantages of CTC over colonoscopy, because when we have residue in the bowel, it's tagged and we know that it's just fecal material and not pathology. We then can use this really funky software that allows us to fly through the colon and get these endoluminal views, similar to what you may see at colonoscopy. And it is a really good first-line test for looking at colonic polyps and cancers. But the problem we have is that we can't obtain tissue. And so for all these positive CTCs that we're doing, we then have to duplicate the test and go on and do a colonoscopy on the patient to obtain tissue and progress their management through the cancer pathway. So, what are the challenges and why did we set up this group to try and improve the CTC pathway around Greater Manchester? So as we said, it is a good first-line test. We're doing around 400 of these tests every month around Greater Manchester, but we weren't doing them very well, if we're going to be honest. If you look at the number of patients having their CTC done and reported within 10 days, which is the aspirational target, we're all like way down at the bottom. We had 2-star trusts who were doing reasonably well, and that was Salford and Bolton. But the rest of us, and MFT in particular, we were flagging way below 20%, which was really slowing down the pathway and not where we wanted to be at all. So we did a bit of a scoping exercise around GM, where we tried to identify what the challenges were to getting patients onto the scanner and getting the scan reported. And it was no surprise what feedback we had from every trust. We were all saying the same thing: inappropriate requests, incomplete clinical information, both really important things, because it's our responsibility in radiology to justify a radiation exposure and justify this reasonably invasive test. And if we don't have the sufficient information provided at the time of the request, then there's a lot of back and forth goes on email between our GI radiographers and the clinical teams, and that can delay things by up to 2 or 3 weeks by the time we reach a resolution. So really important factor that causes significant delays on the pathway. Then we identified that patient choice is an issue. As our trusts are getting bigger and we're offering patients investigations at trusts which are not local to them, it's no surprise really that patients don't want to travel all the way down from North Manchester down to Wythenshawe to have their CT after they've just undergone 24, 48 hours of bowel preparation. And so patients can themselves delay their pathway by choosing to stick to their locality. And again, you can add 1 or 2 weeks onto the pathway as a result of that. Then the next 2 are kind of grouped under the same issue, and that's the informed consent. So we're finding that patients are often turning up for CTC, not realising quite what the test involves, that they're going to have a rectal catheter put up and all this gas put into their colon. And so we have patients, it's not very, very common, but it does happen where they turn up, they've taken all the bowel prep, and then they refuse the test on the day because they don't want to have this rectal catheter put in. So there's a lot of problems around patient education in advance of the test, and people not quite knowing what they're coming for. Another big area that causes a problem is the supply of bowel preparation. So now that a lot of patient consultation has moved towards being virtual or telephone consultation, we have this issue of how do we get the prep to the patients. So we're using post and we're asking patients to come and collect it, but again, there's inherent delays within that system, which are quite difficult to overcome. And then every trust had their own individual issues with capacity, so whether it be vetting, having time on the scanner available, or having reporting capacity. And we know that the latter is a significant problem in radiology currently because of the backlogs. So what did we do then to try and overcome all these problems? So we set up just over a year ago now the CTC Expert Reference Group. It was led expertly by Iridian Bramley, and I helped a little bit. We then had Catherine Walsh, who's the Imaging Network lead, and Roger gave us some brilliant clinical input as well as the Colorectal Pathway Board lead. We were then managed to about an inch of our lives by Jenna Lane, who basically was cracking the whip through the whole thing and making sure that we all attended the meetings and did all the tasks that were being asked of us. And we had membership, and this is really important, from GI radiologists and expert GI radiographers from every single trust around Greater Manchester, who attended pretty much all the meetings and contributed to the development of the new guidelines. So off the main group, we had several smaller subgroups which met more regularly to try and progress the project. We had a triage subgroup that was led by Roger. And again, we had membership from the straight-to-test triage teams, myself, GI radiographers, and importantly, we had patient representatives as well. We then had a really important subgroup, which was the pharmacy subgroup. This was led by the Deputy Chief Pharmacist at MFT, and again, pharmacy lead representation from every trust around Manchester. And they had the really important and difficult job of doing a full pharmacy review that looked at all the bowel preparations, lots of the medication issues that surround CTC, you know, what to do with the meds that the patients are on when you're going to undertake bowel preparation. And then importantly, looking at a lot of the meds that we use as part of CTC, so the important one here being Buscopan, because there are a lot of contraindications, and omitting it does affect the quality of the test. So they did some brilliant work, which I hope will be published soon, and potentially nationally as well. So we started off by setting what we think are optimistic targets for our turnaround times. We think that we can probably achieve 85% of patients being scanned within 7 days of a request, with the scan then being reported within 3 days. So an overall CTC request to report of 10 days. The best practice time pathway looks at anywhere between 7 and 14 days for getting the first line tests underway and completed, but we thought that given our baseline position wasn't great, we went for the midline 10 days, and we think that this will be achievable with the changes that we've made. So we decided as a starting point that CTC should be a test that can go as a straight to test. So from the minute it hits the triage pathway, the triage team should have access to request, issue the prep, consent the patient, and potentially at some point in the future be given direct access to CTC slots. Because there's no need really for radiology to be getting involved again, duplicating the consultation, phoning the patient again, going through all the history again. That was the bit that we found was really slowing down the pathway. And so in order to make it a straight to test, we defined first and foremost the clinical exclusions from straight to test. Age used to be a criterion within this, which we decided wasn't appropriate, given that most of the patients that come through this pathway are of the older age group. And you can have older patients who are perfectly able to have the test and can go through the faster pathway. So we removed age as a criterion, and instead we focused on the more practical things like frailty, Rockwood scores, mobility issues that might interfere with you being able to tolerate the procedure, complex comorbidities, high BMI, and having the capacity to be able to consent for the test. So if you tick any of these boxes, you're removed from the straight to test route, and you have to go through a face-to-face consultation, either with the clinical team or with the triage team as a face-to-face appointment. We then looked at the indications for CTC, and this took a long time. This probably took the best part of a year, because there was a lot of back and forth about appropriate indications for the test. And this went through Colorectal Pathway Board twice, and it went through the endoscopy network twice as well before it was finally ratified. So if we go back to the baseline position, which is what are we doing CTC for? And there's two main things. It's to look for large colonic polyps, so we're good at finding polyps more than 1 centimetre, and it's for looking for colorectal cancer. So yes, it's a test that gives you an overview of the rest of the abdomen and pelvis as well. You get the liver in and the pancreas, so if you've kind of got non-specific symptoms, it ticks both of the boxes. But really, we should be reserving CTC for where colorectal cancer is suspected. And so if we follow that principle, we think that these 4 indications are an appropriate starting point. So following failed colonoscopy is an obvious one. So patients had their bowel preparation, they've had an attempt at scope, it hasn't gone all the way around the bowel, and so it's absolutely reasonable for the patient to come to radiology, have the fecal tagging, and have a CTC either the same day or the following day. Or if the patient's previously had a scope which has failed, or they've not tolerated it, perhaps they've had previous abdominal pelvic surgery, lots of adhesions, kinking the bowel, absolutely reasonable. And then we hit the fit issue, and I'm really happy that Sarah came before me with fit, because I don't have to go into it in as much detail. But effectively, what we don't want to do with colonic imaging is duplicate tests too much. So we don't see the point really in having a test in patients who are at really high risk of having colorectal cancer, where we're going to find a cancer in CTC, and then they're going to have to go on and have a second test in the form of colonoscopy to then obtain tissue to progress their management. And so patients who have a very high fit level, their first line test should really, if possible, be a colonoscopy. And we want to try and reserve CTC for the lower risk group of patients, so those who have a positive fit between 10 and 20. And we hope that by doing that, we'll reduce the capacity issues that might be hitting colonoscopy for the lower risk group, and reserve it for those patients where you're more likely to find colorectal cancer. Then obviously there's patient choice. So a lot of patients think that a CTC is going to be an easier test to have. It probably is a little bit, but you still have to undergo quite intensive laxative bowel preparation. You still have to do all that stuff on the CT scanner. And so it's not an altogether easy test. And we do want patients to be informed of that, and informed as well that if it's a positive scan, they're going to have to go on and have a colonoscopy. So I don't have time within this to go through the whole imaging guidance that we've produced, but it's widely available and hopefully disseminated by the Colorectal Pathway Board. We're trying to work really hard to get it embedded within all the trusts. But again, I'll take questions about that at the end if there are any. So as part of the process, we also put together a standardized CTC request form. So as I alluded to at the beginning, one of our biggest issues in radiology is incomplete clinical information, and that results in back and forth between radiology and the clinical teams. And we hope that by asking for specific detail that is really important for vetting the scans, we'll completely take out that challenge. So we've put this together as a group. It's hopefully not too dissimilar to a colonoscopy request form. And I think once clinical teams get used to filling it out, it'll hopefully not be as onerous as it looks when it's projected on the screen there. We've yet to embed it into the electronic platforms across GM, but we're going to be working on that in the next couple of months. So that's work in progress currently. We also then did loads of work standardising patient information leaflets, so the leaflets that patients are receiving after their consultation, before the test, and also the leaflets that they're given afterwards. So my colleague Andy, who's GI lead for radiography at MFT, together with Jenna, put loads and time and effort together with patient representatives to standardise these request forms. And again, they'll be accessible and able to use across GM. So just to touch on a few of the key successes, this is still quite early work. It was ratified by Colorectal Pathway Board in October last year. But we are starting to see significant improvement in the CTC pathways across GM. We've had some key successes that we'd like to mention. So we've had straight-to-test requesting of CTC introduced at 2 additional trusts. We've had radiographer-led vetting implemented at Pennine, which has had caused massive improvement in the pathway, and imminently the same will happen at Stockport. We've done lots of capacity and demand modelling across all the trusts in terms of scanner capacity, time of day, how can we squeeze more patients onto scanners, and again that's had significant impact at Stockport. And we've introduced at MFT a pilot pathway where the lower GI triage team can request straight into a CT scan slot on the back of positive fit and ticking all the other boxes. And we're very pleased that the early results of that have really been outstanding. We're achieving 7-day turnaround from request to report, which is unprecedented really, and we're really hoping to try and expand the pathway in a view to improve our overall performance at MFT. So just to show you that in graphical format, so this is GM as a whole, average figures. January was last year, so we started off at less than 15% of patients having their scan within 10 days. And you can see where we were at the end of December, so really excellent steady increase in turnaround times, which we're really pleased about, and we hope that will continue to improve. When we break that down into physically getting patients onto the scanner versus getting the scan reported, we can see that the upward trend is because we're getting patients scanned quicker. We're not doing as well with the reporting, but I think that's just a generic issue in radiology, unfortunately, because we're lacking reporting capacity. But there is work going on in the background to try and get radiographers reporting CTC. There's a national CTC reporting program underway, but that takes time. It takes a good 2 years to be accredited as a reporter in CT colonography. So we'll start to see that in the next year or two coming through as improved reporting. And then just finally showing the improvement that we've seen at Pennine, just by the simple thing of introducing radiographer vetting. So this is basically not waiting for a radiologist to sit and vet CTC, but enabling radiographers to vet and to give them the ability to question requests as well. I think that's been really important, and defining inclusion and exclusion criteria has really resulted in this increase. So how can you help us? As with any new guidance, there will be a little bit of ups and downs, I think, with introducing it, but if it forms a change from current practice. We hope to try and embed the new guidance within all the trusts in GM. And really, we need your help. We need gastroenterology and colorectal surgical teams on board. And the aim, I think, if we just all try and remember, is to improve the pathway and get patients scanned and reported faster. And so anything that we can do to help with that is gratefully received. Please keep an eye out for our standardised request forms. And if you do have any questions or issues with the guidance, please get in touch, either with myself or any of the other GI leads at your trust where you work. I'm very happy to take easy questions about CTC. If you have any difficult questions about indications, Roger's your man. Okay, thank you.
So thank you, Dina. Very exciting improvement that you're outlining for us. Now, on my agenda, of course, it says I've got to wait for panel discussion, but I'm going to change that, of course, because I've got the opportunity, because I'm in charge of this little bit, Roger, I'm sorry. I'm going to ask your colleagues to come up and join you, Dina, and I think we want to get into the Q&A on this section directly before we move on to the next exciting topic on the agenda, because I think there's certainly going to be quite a bit of interest in how you've achieved improvements in such a short space of time. So we've got Rydian now, we've got Jenna now, and Roger, and Roger's even agreed to come up as well. Excellent. So my panel of assembled guests, I saw a couple of hands up. Where's the first one? Sarah, over to you, Sarah.
It's just a really simple question, which is what we wanted. If these patients are going to be doing straight to test, then I can imagine there may be some questions coming back to us as to what it involves. Your slide was really, really clear. And I'm just wondering whether we can work on something to put on the GMCA colorectal pathway page and GP diagnosis section, just so that GPs can go straight there and have a really clear idea as to what their patients might have. I don't think you know how many people will look at it, but I think on occasion it would be a really useful thing to have there.
Thank you very much for that. So I'll just start off by saying the most important part for us is the fit, because quite often patients are referred into the lower GI pathway having not had that, and that's the part that is slowing down what happens at the start. So if we have a positive fit on referral, it really helps the triage vetting to go into colonoscopy, CTC, and they have direct access then to go straight into the test. So from our perspective, it will really improve the pathway if we have that. It's still really variable the uptake.
So, thanks, Sarah, and thanks, Dean. It's a kind of, that's a really interesting bit, isn't it? Because straight to test normally causes all manner of controversy, but it seems like you've really got the kind of the angle in with the fit requirements that have got a lot of evidence behind them, and I think you made that very clear. So, I mean, it's very interesting because it's normally the straight to test that causes all the controversy, isn't it, in our diagnostic pathways. I think, who's next? Who's got the microphone? Sekai, you're next.
Thanks very much, Roger. Fantastic presentation, and it shows system-wide leadership. What I'm interested is in, from each of you, what is your key learning? Forget the CTC, but on how you manage to get the whole system working together to achieve these results. Because there's a huge opportunity for us to do similar thing in other areas. I'm just wondering what is your reflection and your learning? 1 point from each of you would be great. Thank you.
So when we started the process, I showed the slide at the beginning of where we were with performance across GM. And we had two standout trusts. One was Salford and one was Bolton. And we were all wondering how are they doing so well, having not done any of this work that we've done yet. And the key thing at Salford that we noticed was that they implemented straight to test two or 3 years ago, and they've got a very strong triage team, which at the outset is doing telephone consultations with all the patients. They have a very protocol-driven indication exclusion criteria, as we've then subsequently developed and improved, and they have direct access into radiology. So it takes out radiology from being that middleman, which we were doing really badly before, because we weren't receiving the clinical information. We had to then do a consultation with the patient. That's another week down the line, adding onto the pathway, and we have to do that to justify a test. If you're going to irradiate someone and give them a significant radiation dose and do 2 scans effectively through the abdomen and pelvis, you have to justify it. And so we had to repeat and duplicate a lot of work that was already happening at the front end of the pathway. And Salford did that really well by eliminating that radiology element and just really bolstering and improving the triage team at the outset. So that was the big learning for me, was to strengthen the front end of the pathway, and that's a really important push for the rest of it.
Great, Dina, to hear that eliminating radiologists is a learning that we've got.
No, I didn't say radiologists.
Thanks, Dina. Rydian.
Yes, I'll go right back to the very beginning because I'm not a GI radiologist and I don't do CT colonography. But being in a diagnostic lead role with the Alliance, I could see that this was a particular challenge for us in regards to performance, and speaking with Lisa and the team. And it's always important to have national guidance, and we had some national guidance about how these things should be improved. So it's taking that guidance and engaging with, we engaged with radiology clinic directors around Manchester and radiology service managers, and got agreement to hold some workshops which were ably supported by subject matter experts and get buy-in to set up this expert group with, and it is incredible if you got that starting point of having the nominated lead who are supported by their team to come along to the meeting, the lead radiologist and the lead radiographer, and together as a task and finish group, it just shows what you can achieve working it through step by step.
Thank you. Yeah, I can comment from a project management perspective because I'm not remotely clinical, but I think some of the success in working collaboratively, I think has actually been around taking our time on this. So we've been working on this for over a year now, and I think when we want to improve something, we often want it to happen straight away, but we really took our time at the start of the project to understand what the barriers were to faster turnaround times, but also we took a long time to establish the group and make sure that we had the buy-in from all of the trusts as well, and I think that has paid off in the end.
We've had a radiographer questioned by police on suspicion of assault for doing their job and undertaking a CTC. So my message would be, don't be afraid to upset people as long as it's in the patient's best interests.
Thank you so much. On that bombshell, thank you so much, Roger, for your bit of learning, which slightly extreme but proves the point. Have you got any more questions? Young man here.
Lena, thank you for the presentation. It was really great. What I wanted to ask was, I think many people who are ordering CTCs don't understand the difference between a CTC and a CTAP. So how can we work to raise awareness that the CTC has lots of additional prep, takes a more robust patient? How can we make it so that you're going to get less inappropriate requests and there's going to be less pushback from radiology when those are coming through?
So one of the other things which I didn't mention in this actually is that we've made it a test that has to be requested only by colorectal surgery or gastroenterology teams. So where it was previously a free-for-all, we'd get referrals from like dermatology and cardiology and also, all sorts, based on conversations with a gastroenterologist, but now you have to tick the box to say that you're either colorectal or gastro, and I hope that colorectal and gastro know what the difference is, hopefully.
Thanks, great question. I've got two more questions.
Thank you very much. James Nicholson, surgeon at Salford. Start with it, I've got a comment and a question. First of all, thank you very much for a huge and difficult body of work that you've done there. I wanted to note the importance of a PR before a CTC, especially if we are moving towards straight to test for CTC, and how important that is then that we have a PR performed at some point in that pathway, either before or afterwards, especially if we're now having that straight to test, and then the GPs, it might be more important that they do a PR, or we have a service that we can have a PR in hospital for these patients. As I'm sure you're all aware, the CTC does not assess the anal rectum very well. The second issue that we've had at Salford, and it's a question, I wonder if we can go back to your indications slide, Dina, would that be possible?
Yeah, of course. So as I do that, I'll just mention that we spent an awful lot of time talking about PRs. Sorry. That's the exclusions, isn't it? Because getting that right is really difficult because patients are mainly being seen remotely, aren't they? Telephone consultation or virtual. And so from our perspective, it doesn't matter when it happens as long as it does happen at some point during the pathway. So we can go ahead and do a CTC without having had a previous PR. we have also created a standardised reporting template, again, which I haven't mentioned because there was no time to talk about it, but which is going to be embedded into Sectra across GM and potentially further afield wherever Sectra is used. And what that's going to do is standardise all the reports, enable us to better audit our outcomes, and so that all the reports look exactly the same for you guys when you're reading them. But as part of that, we have the caveat at the end of the report that a rectal examination is prudent, and that, as you said, CTC doesn't look at the inner rectal junction very well.
Great, thank you.
So thanks for raising that.
Just the question, actually. Apologies. The indications there, I suppose it boils down to, does A and B and D trump C? If a patient chooses to have a CTC and their fit test is 21, is that still indicated?
So I think that may depend on the context, really. And so we've got a caveat that overall, if there is a specific context which can be explained, then it's reasonable for a discussion to take place between radiology and the clinician. We're fallible. We're not going to get everything right, and you can't be entirely prescriptive because patients are kind of inconvenient, aren't they? They don't always get, easily pigeonholed into one box or another. And again, what's the difference between a fit of 10, of 20 and 21? The fit question we debated quite a lot, and we've had some feedback from the Mersey kind of team suggesting perhaps we should be more relaxed about that. But I think there's room for negotiation. And the other thing that we will do is we've put aside time to review the guidance in respect to the feedback that we get. I think we've got that timetable for later this year. And we may well issue a kind of 2.0 just because we didn't anticipate we get this perfectly right first time.
That's great. Thank you, Roger.
Thank you. Surgeons getting as much as they possibly can, which is an important surgical principle, as we know. Last question over here. Far away.
Thanks. Taz Hussain, one of the colorectal surgeons from Wigan. A great presentation. Thanks. My question is about this 10 and 20 of fit test results. Is it evidence-based? Is there any possibility of expanding that further out to a higher number? I know that will lead into capacity issues because most of the radiology departments in trust are struggling with the capacity for CTC and all that, and we don't have enough radiologists to report CTC in most of the trusts. So that's my first question. And second question is, do you not think that iron deficiency anemia should be a part of this indication for CTC with the fit negative patients? Because we know some of the right-side colorectal cancers do not make blood, so fit tests can be negative with iron deficiency anemia, and they can be elderly patients who can't have a colonoscopy. And the last part of the question is, how good is the CTAP with IV contrast and oral fecal tagging as compared to CTC in excluding out cancers or polyps in patients who can't undergo CTC with a positive fit test?
So we've got three questions there. Okay, as a person of limited memory, we'll take them in reverse order. So in terms of CTAP, I'll defer to Dina because I don't know. The second question, what was that? That was iron deficiency. So iron deficiency, I think, is a separate issue to consider, and there is work going on with a non-specific symptoms pathway around iron deficiency. I think that's quite a complicated area, and there's a lot of unnecessary investigation, over-investigation in iron deficiency, and there's lack of complete investigation in iron deficiency as well. So there's work to do there. CTC is part of the solution in some situations, but you alluded to a situation where a patient isn't fit for colonoscopy, and I would argue if you're not fit for colonoscopy, as Dean has demonstrated in that slide, you're very unlikely to be fit for a CTC. And what are you going to do? What's the utility of the result you get from CTC if you're not fit for colonoscopy? Because it's unlikely then you'll be fit for any further intervention. So I think the question around fitness should start with the fit test. If you're not fit for intervention or investigation, what's the point of doing the fit test? Just to torture you with the possibility you might have bowel cancer, which you're probably not going to die from, because you're very likely to die from your comorbidity if you're not fit enough for a colonoscopy. And I've spent so long on that question, I've forgotten the other one.
Fit between 10 and 20.
Oh, 10 and 20. So that was it. So we discussed that quite a lot, and so we took feedback. We discussed it with the Mersey team, shared the guidance with Ash Bassi and the Mersey team, and there's a Northwest Endoscopy Academy which gives us that sort of relationship. But we also benefited from the expertise of Professor Andrew Plum from UCL in respect of where we should perhaps put that fit level, and that was commensurate with what they felt as well. But that is something that we will keep under review, and I think it is. As James said before, where you're borderline and you think there's a good indication for CTC, have a discussion with your friendly radiologist, there'll be room for compromise there.
Okay, thank you. That's the end of our questions for this session.
There's one more question, I think.
Okay. Sorry, fire away, Dina.
That's okay. So a CTC is going to be far and way superior to a CT abdomen and pelvis for finding colonic polyps and for finding colorectal cancer. But as Roger's alluded to, if you're not fit, then what's the point in finding a 10mm polyp? There probably isn't a point. A CT abdomen and pelvis will show you if you've got an advanced malignancy, if you've got an apple core lesion or an annular lesion in the bowel, helped probably by having some fecal tagging on board. So in terms of managing patient expectations, we do a lot of scanning in people who are not fit for treatment, but to manage their expectations and to manage palliative treatment and to manage expectations of relatives and things. So it's not unreasonable to scan to do an abdo-pelvis CT, knowing that we're not going to pick up the small lesions, but in these patients, do they matter?
Okay, thanks, Dina. I am going to stop us in the session. Don't run off, Roger. And I just want to get everybody to thank Dina and Ridian and Jenna for a great demonstration of an improvement programme that's been going on in CTC in our colorectal pathway. And just remind everybody that Dina did ask us all in the colorectal community here for a bit of support. And just a reminder on the final slide there, it's up on the screen. And just want the colleagues around here to give you a big round of applause for the progress you've got so far. Thank you very much. I'm going to move us on now to the next exciting presentation, which is all around the early findings of the Gallery trial in colorectal. I'm going to invite Becky Duggan, who's an Assistant Director of Nursing in Oldham and involved with the Community Diagnostic Centre there, to come and tell us all about it.
Thank you. Afternoon, everyone. So I've been asked to come and talk about the Gallery trial. We're into the third year now, so we've been able to look at the data we've got back and collected from year 1 and 2, which are confusingly called year 0 and year 1. So yes, we're going to look at it in a specific colorectal light here. So just a quick hands up, who in the room has heard of the Gallery trial? Excellent, that's a lot better than it used to be. And how many of you have actually seen a patient or treated a patient, been involved in a patient? Brilliant. Okay, so for those that aren't very aware, but that doesn't sound like many anymore, thankfully, it's a multi-cancer early detection test, looking for the DNA methylation signals associated with the DNA in the patient sample. It comes back with one of 21 possible cancer signal origins. I won't go through them all, they're there. And the one we're focusing on today is the colon or rectum cancer signal origin. And the sensitivity of that is pretty high, around 82%. So just a bit about how the test worked and how the trial worked. It was open to patients between 50 and 75, and they asked out for volunteers. And we got around 20,000 participants in the first year, which was sort of 21 and 22. Of those, half of them had their blood taken and put into a control arm, and the other half were active. So you can see sort of the stats there, the middle column for year 0 and then year 1. So about 1% of those participants in the first year, slightly lower in the second year, came back with a positive cancer signal origin. Now, so surprisingly to us, actually, we weren't expecting it, but most of those, a high proportion of those, around 72%, came back with 2 cancer signal origins. These are quite often paired in sort of similar areas of the body. Sometimes they could be completely unrelated, so you have to investigate both. Of those that came back with a cancer signal origin that was positive, 49% of those had a cancer diagnosis in the first year, and then 59 in the second year of running had a cancer diagnosed. So, you know, if you compare that to your conversion rate on a symptomatic 2-week wait patient, it's pretty exciting, really, that these are asymptomatic patients, and 50% of them who, roughly, who are getting a cancer signal origin have a cancer. So, you know, it seems to be working quite well. Most of them, around 80%, did match their first likely cancer signal origin. They give you a likelihood, so the first one and the second one. Some did then actually turn out to have their second cancer signal origin, and there were a few that actually had one that wasn't related to what they'd found in the blood, whether that was incidental or whether it was just a slight misread. And then, more excitingly, I guess, is looking at the percentages in those people who were early stage, so stage 1 and 2. And in the first year, we were around 50%. It's dropped off slightly in the second year of looking at it to 35%. But again, we're really early in that trial, and there's lots more data to be gathered, so we'll see what that looks like as we go on. So for the first year, year 0, you can see that the colorectal was the most commonly found cancer diagnosed. I think that equated to about 8 people in the first year diagnosed with a colorectal cancer. Other common ones, prostate and lung, and again, we found similar findings in the second year of running it. Again, colorectal was the most frequently diagnosed cancer from the Gallery trial in GM. Looking at the early stages, so you can see again in the first year, like I said, it was around 49% that were that early staging. You can see it broken down there specifically. Again, slightly more stage 3s in the second year of running, but still a fairly good chunk of them with early stage diagnosis. So the template on this side is what we ask the trust to send back. So the trust are filling in the information for us as a Gallery task and finish group that meets very frequently to look at the data, any problems we're having, and develop the SOPs, etc. So looking specifically at colorectal cancers that we diagnosed here, you can see that in colorectal specifically, you know, there was a huge amount of them were diagnosed with stage 1 and stage 2. I think there's only 1 in the first year that had a stage 3 diagnosis, and the majority really were in that early window. And then again, looking at the second year we ran, it's still, in colorectal specifically, it was still over half of those diagnosed had a cancer in stage 1 or 2, slightly more in stage 3, but again, it's still pulling people out with fairly early stage diagnosis. So year 3, but year 2 so far has now started. The vans are going round, and the blood draws are running until July, so you'll continue to get those referrals through to your practice throughout the year. And currently we've had 23 referrals. I don't actually know how that equates to the previous years, but we've had, from year 0 to year 1, we had sort of an 88% comeback rate for the patients that were involved, and they worked really hard in GEM with the comms to get those patients back in, so we're hoping we'll get the same or even better return rate this year. Once the trial has finished, so this is its last year in the initial trial phase, you might have seen that it's being rolled out across cancer alliances that didn't run Gallery, so there was only a few cancer alliances that did this trial. It's now going to be rolled out to the cancer alliances that didn't involve themselves in the first trial. So at the end of this year, we will actually have a bit of a hiatus, and we will return to business as usual, which feels like a bit of a shame in some ways, but we're waiting for that larger implementation trial to run, and then obviously all the information and data to be gathered for then deciding what we do with it and who we roll it out to, how we roll it out. So a bit of a whistle-stop tour through some of our results there, and a bit of a caveat. Please don't ask me anything about the molecular science involved in Gallery, because I will again just defer you to Roger or someone much smarter. But yeah, any questions?
Come and have a seat.
Thank you.
Becky, thank you so much, Becky, for that really quick run through what is an emerging, very exciting development, isn't it? I'm going to ask Roger to turn back up here and try and avoid any questions about false arrest and that sort of thing in this session, and invite colleagues to ask Becky any questions on what, you know, is one of the emerging projects in the national early detection programs that we've got running on. So if we've got any questions for Becky about this exciting thing. Sarah,
sorry, yeah,
you're first.
Yeah, sorry. It's just whether or not the patients who were diagnosed with colorectal cancer were eligible, had screening, and if so, was it positive or negative? Do we have that data?
That is a really good question, and I have absolutely no idea, but we can get that data. So, yeah, I'll speak to Sophie and we can look into that, because you're right, that would be really interesting.
I was wondering whether Gallery is as good or better than FIT.
Yeah, I mean, obviously, the aim is to get the early cancers. So I guess in some cases, you'd almost hope it might be a precursor to a FIT test being positive. So it's something we'll look into.
So it's a great question, isn't it, Sarah? We know that there's a load of national data set requirements in this, isn't there, Becky, that I'm sure you've been wrestling with, and all of those data parameters and more are in that national data set. I think there's all sorts of difficulties in the commerciality of the activities in what is this enormous trial, isn't there, Becky? I know that's going on at the moment, which means that you're not really allowed to do very much with the data that's available. Is that's a fair summary?
Absolutely,
isn't it,
yeah. It's not being released on a large scale, so we've stored our own data in GM just to try and spread the word like this. But yeah, you're right, that it's not officially been released yet.
Sure. Okay. Next question, young man over there.
I'm 50 next week, so thanks for saying I'm young, thanks. How much does it cost for the test?
Oh, see, I knew I wouldn't be able to answer many of your questions. I don't know. That's a very good question.
The very test, important.
The blood goes over to America to be analysed, so probably a fair bit, but I don't know how much it's costing them. It's run by the company is called Grail. So the company that do it is called Grail, and they're using the NHS as part of their test bed. So, but I couldn't give you a specific figure.
So
oh, there we are.
Yeah, I guess the answer is we don't know, and we can't know unless and until it's agreed that it's a commercial proposition and that the evidence base supports it, and then the price will be determined by the volume and the deal that is cut, I guess. If this scales up and it becomes high volume, then the cost per patient will or per blood draw will probably come down, but it opens up some interesting ethical questions about how this could be afforded in future.
So thanks for the interesting
question for me.
Thanks for the helpful bit of internet advice. So I declare a tiny little bit of knowledge in this area. Let's be clear, this is a commercial trial. There are other platforms. This is being tested. I think Johnson & Johnson are actually the owners of this particular platform and trial, and the commercial activities of NHS England in participating and procuring this particular test and trying it out are quite complicated and the subject of some consideration in a number of debates, and the absolute answer to the question about how much our test costs in this existing trial is unknown for us at the moment. That's the absolute answer to that question, which is interesting, isn't it? Next question, young man at the front.
Yeah, I mean, having worked in America for some time, and I know they do some similar tests over there called Colorectal, where they basically pick up the DNA methylations and stool for screening patients for colorectal cancers. Now, I work in Cleveland Clinic where there was big hereditary colorectal cancer services set up, and then when we used to screen the patient over there, we used to find a lot of variants of unknown significance. Your cancer signals are going to throw up that. What kind of a psychological support have you got for those patients where there's all this unknown significance being thrown off?
So at the moment, the patient handling is handled by the trial team who are based down in London, and they've got lots of nursing support and sort of navigator patient support who will phone the patient and talk them through this result, and they will be very clear that this, in a similar way to when you're referred on it from your GP, it won't necessarily be a cancer. But I agree, we raised this ourselves at the beginning about what are we going to do with these patients. you know, when they've had this blood test which says you've got a, you know, cancer and then nothing's found. I think there's an element in when you're involved in the trial that they know they'll be coming back every year, which provides a certain level of reassurance. And, you know, as part of the Gallery trial, they have a CT tap, even once they've had their, you know, site-specific investigations. So we're able to provide a fair level of reassurance that we are investigating you, you know, pretty thoroughly. But I agree that there is some holistic hand-holding, and primary care can't pick that up because at the moment, primary care aren't even actually involved. The referral comes directly from the trial team to secondary care. So, you know, GPs won't even know necessarily they've got a patient on this trial until the discharge letter comes through. So again, part of the reason that we put the patients in GM through the NSS service, the rapid diagnostic centres, is that it inbuilds that level of patient support before they've even gone on and had the diagnostic. So that's something we've done. You know, we've got nurses who lead on the Gallery trial in our team that will handle that patient communication. I agree, there's only a certain amount of reassurance you can give, but that's how we've tried to handle it.
It is a bit of a curate's egg in a way, in that we might make an assumption that if a patient's asymptomatic and diagnosed with a cancer, they'll be absolutely delighted. I had a patient in his mid-70s who came to me for a colonoscopy to remove his colonic polyp because that was his second CSO, but the first CSO was an early diagnosis of a life-threatening cancer for which he'd had life-changing surgery, and he was really quite undecided about whether it was a positive experience or not, and you know, complex emotions around feeling, did he really benefit from all of this? You know, I was pretty certain that he did because of the nature of his primary cancer, but he had no symptoms at all, and he'd been made to feel quite unwell from his curative surgery. So it is a difficult situation psychologically. It's not straightforward.
Thanks, Roger. I think it's a great question, isn't it? Because I think it's applicable to other things that are at the front edge of being tested in the early diagnosis space. And it's a kind of common feature, this question about the kind of psychological safety of patients in that area. And I'm absolutely sure we'll see it in a number of the other early diagnosis arenas. So very important. And I guess very difficult to work out what the ethics are while we're doing the trial bit of this sort of thing on a national basis. Very interesting. I've got the same young man's gone back for a second question. Ridian,
looks like
Ridian's next.
Yeah, thank you very much for the presentation. There's a number of products in the market around here on liquid biopsies and early diagnosis. Are there any lessons learned from this that would enable us to evaluate some of these other products in a controlled and coordinated way to put us on the forefront in Greater Manchester of this type of innovation?
I'm sure there will be, but like I say, we're not privy to those yet. You know, all of the analysis is being handled centrally. We're collecting our own data, like I say, locally, but it's very high level. So I'm sure there will be, but I don't think we're going to be able to get ahead of the curve specifically from Gallery because, like I say, we're not doing it locally. It's nationally held and nationally evaluated. So probably not yet.
Yeah, a lesson from human history is that the technology comes first and the ethics come second. Always, you think of the time lag between the invention of the wheel and the traffic light. It was substantial, but it's getting shorter. So there is a need to really consider the ethics of all of this. And there's a variety of things. There's a number of cell-free DNA products. There are some products which are looking at the microbiome, and of course we've got genetics and genomics together as well. And we've also got big data that may be able to determine what our personal risk of cancer is depending on where we grew up, where we're educated, and where we live now. We put all that together, we could have some really powerful tools to determine what happens to you, but we really need to think of the ethics of those. And what else have we got? We've got volatile organic compounds exhaled in breath, which may well also determine personal risk of disease, not just cancer. We've got to be really careful being too optimistic about all these, because we've got those spoil sports public health doctors in and around the room who will say, well, hang on a minute, are you going to be finding cancers that people die with and not from? Because that's a big risk in all screening programs too. And the number of screening programs that demonstrate a reduction in all-cause mortality with evidence is exactly zero. So we've got to keep all that in mind before we get too excited about all this. And it is important to be patient, get the evidence right and deploy it properly.
Can I just make the point that using it in the asymptomatic population, it's £400,000 per cancer, which is a lot of money. But if you used it in the vague cancer pathway, you might get more results. Just that sort of observation, maybe.
Yeah, thank you very much, Phil. We've got to be really careful when we think we know about the finances behind a commercial trial nationally procured by NHS England. So let's just be careful in our understanding of the finances that are behind it.
But moving away from the finance, sorry, that there is interest in CUP. So I know that CUP are really keen to sort of look at this technology. So you're right, it might not be, that wider screening, but there are really specific examples that can benefit. So yeah.
I mean, it's clearly an interesting area at the front edge of a few things here. Roger's pointed out to us. I'm not quite sure I've equated it to traffic lights and wheels, but it's really important. And as you say, Rydian, I think there's lots of other sort of commercial offerings out there. And I think if we listen to the NHS England question, it would be that's exactly why we've got to do a very large-scale trial at a national level on this to generate the evidence and the data, even though it's got ethical trickiness involved in it. Next question, Dina, you've got a question.
Sorry if I missed this as part of your presentation, but how are patients recruited to the trial? Secretly.
So in Greater Manchester, it was 20,000 in the first year. I don't know off the top of my head how many that was, but it's going to be, like I say, the implementation trial at the second arm, which is now happening, is going much bigger scale. So in some ways, from a logistics point of view, we're a bit relieved we were part of the initial trial, because, like I say, that it's much bigger numbers, and it's not actually the trial team doing the blood draws now. It's going to be individual trusts having to sort their own arms. So we kind of got away lucky, but at the same time, it would be good to be able to offer it wider. So 20,000.
Which patient? How are they identified, the 20,000?
They were invited, so the age group, there was a caveat that you couldn't have had a cancer diagnosis within, I think it was the last 10 years, and people were just basically invited by letter in that age group to come forward, and then they'd be accepted onto the trial, so it was volunteers. Thank you.
Great, thanks, Becky. Any other questions on this interesting, exciting, emerging front-edge early diagnosis programme? Any other questions? If not, I think I've gone 1 minute over time, Roger. I think you were congratulating your chairing of the first session. But I'd just say an enormous big thank you to Becky. If you could put your hands together, Becky. Giving us a great insight into some front edge activities in this complex but yet exciting area. So well done and thank you. And thank you to all your colleagues that have got our patients into a position where they can be involved in some leading edge activities. I think that's the main thing, isn't it? So very big thank you. And I'd just say thank you again to all our colleagues, Dina, Rydian and Jenna, in this session that we've had before lunch. There are two exciting sessions this afternoon, but we have come almost to the point now where you are free to have lunch. Look at the art exhibition in particular. I've got some art exhibition exhibits here, but also point out that we've got fantastic poster set up, which I just encourage everybody to have a look at during the course of the lunchtime. And after lunch, the first, I think, up after lunch, is an award for the poster. So everyone getting very excited, I'm sure, in anticipation of that. So we're going to have our lunch session now, and we're going to come back at 1:45. 1:45, we're going to be back here. I'll hand back over to Roger, because I'm sure he'll tell you something that I've forgotten or missed.
Thanks very much, Roger. So just that there are stickers on your tables, so you've got a sticker each to put on the poster that you like the most. That means that you've got to read all of them, and don't be influenced by anybody else's sticker, which is what I usually do in these sorts of things. So put the sticker on the one you really think is the best. Thank you all again for your time and attention, and thank you for the engagement and the fantastic questions that we've had. Really enjoyed the morning. Looking forward to the afternoon. But now it's the best bit with a probiotic, prebiotic, macrobiotic, antioxidant-filled anti-cancer lunch for all of you. Enjoy.